Hello, good evening. Welcome to my MVF&x and the European Fertility Society. We are back once again. Thank you so much, everyone, for joining. It's going to be a great and interesting session, I'm sure. And we already have Dr. Elena Santiago with us from VIDA Fertility. Welcome back. How are you? It's been a while. I'm happy that you are back and you are going to discuss PGTA today. How are you?
Yeah, that's it. Thank you so much for having me today again. I'm very well, thank you.
Happy to have you. And of course, before we start, as always, please let me remind everyone that we are here to discuss PGTA, risks and benefits. And of course, we will start with the presentation. Dr. Santiago will explore when it's advisable, when to use PGTA, how it works. But of course, as always, afterwards, there will be time for your questions. And please just put those in the chat so Dr. Santiago can help you out. And as always, let me remind you that this is a free space. You can definitely anonymously put your questions. We are simply here to educate you, to help you out with any concerns as well. It's never easy. It's never yes or no kind of question, as we know. So we are definitely happy to be able to bring this to you, and so that you can simply find out a little bit more details on our on PGTA and other aspects of it as well. So that will be it from me at this point, and I think we can start with the presentation. Let us know that you can hear us and see us, so we can make sure and we can simply proceed with the event. And I think we can start with the presentation, right?
All right, thank you so much, Caroline.
Perfect. Thank you.
So, yeah, today we are talking about PGTA risks and benefits. For those who don't know me or haven't met before, my clinic, it's VIDA Fertility. We are in Spain. We have two centers in Madrid and Alicante, and we are experienced specialists that are already trained in cutting-edge techniques and very committed to innovation. We give very tailored treatment plans. We have a dedicated doctor and coordinator individually for each patient, and we are expertise in remote treatment management. That's why we have multilingual support to ensure clear communication. The overview of our treatments, obviously we have IVF, but also egg and sperm donation treatments, fertility preservation, genetical testing, that's what we are talking about today, and also treatment options for single mothers and LGBTQ families, as well as regenerative medicine. So, for the topic of today, I want to explain, first of all, what PGTA means. So, the PGTA stands for Preimplantation Genetic Testing for Aneuploidies. It is a lab technique that we use in IVF treatments to analyze the chromosomes of the embryos before they are transferred to the uterus. For this technique, we do need to do an embryo culture until day 5, day 6, where we call blastocyst stage. So here you have the images of the culture of the embryos since an egg is fertilized. This will be day 2, day 3, day 4, and this will be day 5, day 6 at the blastocyst stage. The technique of the PGTA, to understand it well, we need to also see a little bit more about these blastocysts. The particular thing about them is that they are much stronger embryos. They already have different structures that we can see, so we can see perfectly, the inner cell mass, which is this structure inside. This will be the proper fetus or the baby in the future, and this will be surrounded by many cells, which is the blue part that we call the trophoectoderm, and this will be the placenta in the future pregnancy. What we do is a small biopsy of this outside part called the trophoectoderm. Here you can see with more details this technique. So what we are doing is normally opening a little bit what we call the zona pellucida, which is like the capsule of the embryo. This normally is going to be done using a laser or micromanipulation tool, probably in a previous stage of the embryo development. This depends on each embryologist, but normally maybe in day 3, they do this small hole in the zona pellucida, so that afterwards, when we have the embryo, we can aspirate and do the biopsy. Okay. Once we have the cells, this will be sent for genetical testing, normally to an external lab, and the embryo will be frozen at the proper clinic so that we can wait for the result, which can normally take around 2 to 3 weeks time. What will be the possible results of the PGTA testing? So we can have euploid embryos. This is what we want because these are the normal chromosomic embryos. We can have also aneuploid embryos. These are the ones that will have chromosomic disorders. Then there's an intermediate option, not so frequent, but we can also have a result of a mosaic embryos. This means that some of the cells that were tested will be normal, but others can have abnormalities or chromosomic disorders. There's also another possibility when we are not able to have a result or inconclusive result. This unfortunately sometimes happens because for the genetic testing, they need to culture the cells that we obtained with the biopsy, and sometimes this culture doesn't work properly. They need to have cell divisions to see the karyotype, the chromosomes, but sometimes this unfortunately doesn't work. So in this type of embryos, we need to decide whether, for example, biopsy it again or maybe do the transfer without knowing the result. The indications of the technique will be normally those patients, women over 38 years old, so that we can improve the success rates after the transfer. But also it is advised to do it in, for example, patients that have known chromosomic disorders in their own karyotypes, or if they come from recurrent miscarriages or other treatments with implantation failure. We use it because it allows us, as I've already explained, to have the karyotype of the embryo. It's true that the reliability of the technique is not 100% because we are not checking every cell of the embryo. As you've seen, we are only testing a small part of the embryo and also the cells that belong to the trophoectoderm. It's true that this should be normally the same as the inner cell mass, but sometimes there could be some differences between those cells and the ones in the inner cell mass. So that's why the reliability is not 100%, but it's quite high. It's between a 90-95%. Why do we use it then? Well, to explain you a little bit more the reasons why to use this tool is because aneuploid embryos, which were the ones with chromosomical disorders, are going to increase a lot within women's age. This increase of the abnormalities is going to decrease the chances of having a pregnancy and also increase the chances of having miscarriages. Here you can see the relation of the age of the women and the number of embryos that are healthy. So you can see that from 35 years onwards is always going to decline within age. And we compare as well with the donors that normally have a very good rate of normal embryos. Here in this table, you have a better approach where we can see that egg donors normally are around 60% of their embryos normal chromosomically. Patients lower than 35 years, it's a little bit lower, maybe around 50%. But when age increases, you can see that the percentage of normal embryos is going to decrease quite a lot. And that's what it makes it so difficult, even with a treatment, IVF treatment, to achieve a pregnancy. Here we are going to explain a little bit more the results that we can get with the PGT-A testing, related also to the likelihood of producing a healthy pregnancy, because we are not only looking forward for a positive pregnancy test, we also are looking forward to have, obviously, a healthy ongoing pregnancy. So that's why PGT-A testing is very, very important within age. As we've said, the normal embryos obviously will be recommended for a transfer, and the likelihood of producing a healthy pregnancy is going to be quite high. This is more or less a 70% pregnancy rate, even when patients are older. So this percentage doesn't change so much within age if you do have a healthy embryo. The difficult part with the age is going to achieve a healthy embryo. Afterwards, we have the aneuploid embryos, which will directly not be recommended for a transfer. So these embryos, we normally don't use them at all. And this is because the probability of having a healthy pregnancy is very, very unlikely. This is going to be different with the mosaic embryos. As we've said, they have a mixture between normal chromosomical cells and some chromosomic disorders in some of the cells. It's true that this can reduce the possibility of having a healthy pregnancy, but we need always to discuss for each particular embryo, depending on the abnormality that they found out, if maybe we recommend the transfer or not, because there's been described in literature lots and lots of healthy pregnancies until now with this type of mosaics, depending on their grade. It's true that we say the low mosaic have better chances. As I said, it depends on the chromosomic disorders that they find out. And also what we normally do is check it with a genetician, with the patients. They have a consultation together to talk about their particular mosaic embryo and see if they wanted to transfer or not. They can decide, okay? And for the no result or inconclusive embryos, normally we recommend to rebiopsy. It's true that for that we need to thaw the embryo, do another biopsy, and again freeze it. So there's more manipulation, and maybe this could affect a little bit implantation rates. But it's true that we've had already pregnancies with these embryos that have been rebiopsed. So if the decision was to go for a PGT-A testing, we do believe it's better to recheck the embryo rather than doing a transfer without knowing if it's going to be healthy or not. What the results are going to mean in overall, here you can see, as I've said, with the PGT-A testing, achieving a pregnancy or, well, live birth. It's better that we see a live birth rate rather than pregnancy. Here you can see that it doesn't change much within age when using the PGT-A testing. And we compare this with IVF without a PGT-A testing, where you can see that the chances are lower and lower. And with, for example, 44 years old, we have less than 5% live birth rate compared to PGT-A testing, where the live birth rate is going to be near 40%. So we are going to talk now about the benefits and the risks, which was the topic of today's webinar. So first of all, why or what are the benefits of the PGT-A testing? So as we've already said, it increases implantation and ongoing pregnancy rates with patients that are older than 35 years old. So here you can see again the differences, this time in implantation rates and also the delivery rates per transfer when doing PGT-A testing changes a lot when not doing PGT-A testing within age. Okay. Then, as it reduces the risk of having chromosomic disorders in the embryos, we are also decreasing quite a lot the miscarriage rates, which are going to be already quite high within age. Or the majority of patients that are older or 40 years old, the miscarriage rate is going to be quite high. So this is another advantage of the PGT-A testing. We also need to understand that it's not only a matter of improving the rates, reducing miscarriages, but also it's going to optimize the time to pregnancy. This is better to understand as well in patients that maybe can achieve several embryos that are not so old. Let's say, imagine a patient of 35 years old that has a very, very good ovarian reserve and achieves, I don't know, let's say 8 embryos, which is not something very normal, but it happens. Maybe half of those embryos can be abnormal chromosomically, and sometimes you need to transfer quite a lot of embryos until you achieve an ongoing pregnancy. This for the patients also needs to be taken into account because they're going to spend lots of money in transfers, lots of time. They're going to be very frustrated if they don't get the pregnancy. So it does help to achieve a pregnancy before in time, and this helps a lot the patients, obviously. Another benefit that I have to talk about, one of the things that patients maybe are a little bit afraid of when doing PGT-A testing is about the damage of the embryo. Well, we need to understand that right now we are very used to do this technique. It's not something new nowadays. The majority of the embryologists are going to be already trained. So when we do have well-trained, skilled embryologists, we shouldn't be afraid because the impact of the biopsy normally is going to be very, very low. So let's say that in terms of benefits, it's going to be better to do the biopsy rather than don't do it because I believe that the embryo is going to be damaged. As we were talking before about the time, obviously it's going to avoid the transfer of embryos that don't have any potential for implantation or ongoing pregnancy. Normally, the embryos that are aneuploid or abnormal chromosomically are not going to implantate directly, or if they do, they are going to normally provoke a miscarriage during the first trimester. So it's another way, of avoiding transfers of embryos that are not going anywhere. Then one last point that is very, very important as well nowadays. It's true that as we normally work already in a blastocyst stage with all IVF cycles, this is already helping us a lot in the majority of patients in doing a transfer of only one embryo, what we call single embryo transfer. This helps us to avoid having twins or what we call a multiple pregnancy. Sometimes patients don't understand why we avoid this, but in medical terms, for the pregnancy, either for the mother or the babies, it's better if we try and have a single pregnancy. It's true that not always when doing the transfer of one embryo, you are going to have a single pregnancy. Sometimes this embryo can divide by itself. It's not a very large probability, it's around 1%, but this can also happen. So imagine if we do always double embryo transfers, you are going to get lots of twins, multiple pregnancies that are going to be more risky for women, but not also two fetus or two babies. Sometimes if the two implantate and then one of them divides, you can have a pregnancy of 3 or even 4, which is not at all good for the patient or the babies. It's going to be very, very risky. So nowadays, we try to avoid as much as possible the double embryo transfer in the blastocyst stage. We always talk to patients about that. We explain the risks. And when doing PGT-A testing, I mean, 100% of the transfers are going to be single because there's no point in doing a transfer of 2 euploid embryos. Maybe if you didn't do the PGT-A testing and you have 2 embryos, you can still do a double embryo transfer because maybe one of them is not healthy and this kind of things. But when having the testing, there's no point at all in doing a double embryo transfer. So it encourages us doing more safe single embryo transfers. And now I'm going to talk about the risks of the PGT-A testing, or let's say the disadvantages. This is not a risk, but it could be a disadvantage in terms of timing, in terms of maybe imagine if patients come from abroad, they do need to maybe do 2 trips to the clinic, one to do the egg retrieval and the second time for the transfer. So as we do need to freeze the embryos, we are going to delay the transfer and do it at another cycle. It's true that it's not all negative, let's say, because, for example, if patients come for a fresh embryo transfer, they need to stay normally in our country. If they come from abroad for at least 5 days, so that we can do the egg retrieval, and 5 days later we do the transfer. And also without having the guarantee that we are going to achieve embryos of good quality for that transfer. So in overall, I think it's maybe even better in doing the egg retrieval and then freezing embryos, having the results of the PGT-A testing, and at another time, we can do the transfer. Nowadays, also, you know that we are doing many frozen embryo transfer in natural modified cycles. Whenever is something that we can do, if the patient has regular natural cycles and all these things, which also gives us benefits in terms of avoiding preeclampsia, hypertension during the pregnancy, avoiding taking some medication, either estrogens or gonadotropins for the endometrial preparation. So it is considered, let's say, a disadvantage for PGT-A testing that we have to always delay the transfer. But if you look at all the details, maybe it's not so negative. Also let you know that it is technically possible that we do the biopsy in a day 5 of the embryo, and that we can have the result the day after, is if we ask for it to the lab. This is also a possibility, but we don't use it at all because we don't recommend to do the transfer next day, which is at day 6 for the embryo. And in the literature, the evidence that we've seen until now within the investigations, we've seen that implantation rates are going to be lower because the endometrium is not going to be very synchronized to that embryo. There's like we lose synchronization, or maybe the window of implantation is no more good, let's say, for that patient. So we prefer to freeze the embryos after the biopsy and receive the results 2 to 3 weeks later on, and do the transfer at another cycle. Another risk that obviously we need to talk about, as we've said before, is the risk of harming the embryo during the cell removal. Obviously, you are manipulating a little bit more the embryo when doing the biopsy. It's true that it's not something very aggressive. It's true that also we need to understand that the embryo is very, very strong in the blastocyst stage. It has loads and loads of cells. I'm talking about hundreds of cells. So removing 5 to 10 cells shouldn't be so harming. As we've said, if the embryologists have already a very good technique and lots of experience. But, well, obviously we need to take into account that sometimes it still has a small risk of this harming. Maybe afterwards the embryo doesn't survive to the thawing or things like that. It's not something that we see at all very frequently, but sometimes this could happen. Then I also wanted to talk again about the differences between the results. As we've said, the reliability or accuracy of the testing is not going to be 100%, it's around 90-95%, which is quite high, but still we have that 5-10% probability of having either false positives or false negatives. For example, sometimes we can have a result of an euploid embryo, but in reality, the embryo does have genetical disorders. And afterwards, we can have a pregnancy with genetical problems still, which can always be checked in the first trimester, as always. And if anything is found out, well, see what is going to happen afterwards. But this is one of the problems that could still be happening, because it's not 100%. In the other way around, sometimes maybe we are missing embryos that are classified as aneuploid, but in reality they are euploid or mosaicism, that are very low grade, and therefore very, very good chances of having an ongoing pregnancy. And maybe we just biopsy the wrong cells, which were with abnormalities, and we decide not to transfer that embryo. This could also occur. So, I mean, it's a very good tool, but obviously it's not absolutely perfect. And another thing that obviously is not an advantage, or it's a disadvantage, is that obviously using this technique in an IVF procedure is going to cost more for the patients. It's not something cheap at all. But in overall, I think it's better if we use it as no, maybe we are going to decrease also the price of doing many transfers of embryos that are not going to produce an ongoing pregnancy. So we have to look at it like that. Maybe at first, no, we do have to pay quite more than a basic IVF treatment, let's say, but in the end, maybe it's going to be better, not only because we are going to spend less time and have our wished pregnancy before, but also maybe we are going to avoid doing many embryo transfers. So this is going to reduce afterwards the total costs. So what are the taking home messages for today? Quite simple. PGT-A testing, as we've seen, can reduce the miscarriages and help select better the embryos that have the best potential. But it's not risk-free and not universally beneficial. This is not something that we say this tool needs to be done always because it's going to improve always the chances. Not at all. That's why its use should be always individualized to each case, depending on age of the patient, first of all, and also taking into account if parents have any chromosomal disorder, as we've said before, or if they come from recurrent miscarriages, or they've done many treatments with implantation failure. I think those cases will be good to have a new treatment, maybe with the PGT-A testing, can help us to achieve the pregnancy in the end. So that's all for today. Thank you so much again for your attention. Hope you've learned something more today, and obviously now I'm open to receive all the questions.
Perfect. Thank you so much indeed for your presentation. And it's never an easy topic, so I'm really happy that we are able to discuss that. And of course, there are some questions in the chat. I'm sure you can see those. And before we do, let's review it briefly, okay? And then, of course, you will have more time for your questions. So some of you actually already asked about it because you also, it's a common question. When it comes to the PGTA and embryos created from donor eggs, how does it work? Is it always suggested when, or if not, when is it suggested?
That's a very, very good question, Caroline. I didn't mention it, but it's true that sometimes we do suggest PGTA testing as well in egg donation treatments. Obviously, not because of the age. Donors need to be aged less than 35 years old here in Spain. So that's not why we recommend, but sometimes it depends if patients come from several treatments that don't work, several miscarriages, and they need to have as less transfers as possible to achieve the pregnancy as quick as possible and have like the best chances. We do suggest to do it. So not always, but sometimes, it could be beneficial.
And actually, I will go straight to the question that we've got from Christina here, okay? For a 44-year-old with donor egg and sperm donor and 3 failed embryo transfers with different donors, would you suggest PGT?
Yes. So, because of all this failed embryo transfer, maybe no. Obviously, we need to see other factors. It's not only the embryo, but let's say to do things as quick as possible to achieve the pregnancy as soon as possible. I do suggest that you do it.
Yeah, exactly. Of course, that's why I wanted to start with that question, because actually we do have a few of those, and there's another one right here. What would you recommend in case where the donor is young, right? 20 years old, and the sperm is from an older adult, 50-year-old with no known genetic abnormalities?
Yeah, but I mean, always we do have the chance, even with double donation treatments or egg donation treatments with young donors, to achieve abnormal chromosomic embryos. In particular cases where we need to achieve a pregnancy as soon as possible, we had previous failures, I do recommend to go ahead with it. But also maybe other studies for the patient that haven't been done before. It's also important to see other factors.
Okay, I believe that was useful for you. Thank you so much for your questions as well. And before I move on to other questions from you, can you also tell us how accurate is PGTA?
Yeah, so we've talked about it. It's 95% rate, which is not bad at all. Huh?
Definitely sounds good. So just wanted to review it as well. And let's have a look. I will go through your questions and keep them coming. Okay, we are definitely here to answer your questions. So here's the question, 2 questions from L here. If someone turned 38, so do you automatically recommend PGTA, or you still have a discussion with the patient? How does it work?
Well, at that point, we still have a discussion because for us, like the indication is in more than 38 years old. With 35, we have to see the situation, whether it's their first treatment, for example, whether they are going to have very low amount of embryos. In those cases, I don't think it's going to help us a lot. But if, for example, there are patients that have the woman has a very large AMH level, you expect to have loads of embryos, then maybe for her, for that case, it's going to be better to do this extra selection. You obviously need to explain it to the patients, and in the end, they decide what they prefer.
That makes sense. Thank you so much, Elle, for your question. And yeah, so next question is actually what percentage over 38 go through this procedure? Are you able to give us a number? More or less?
Yeah, the majority. I mean, at least for my patients, because I do recommend it at all to all of them. I would say maybe 80 to 90% of them go through the PGT-A testing. Yeah.
That's quite a high percentage here. Yeah, but of course that explains it. I think so. Thank you for narrowing this down, and thank you, Elle, for your questions. How many PGT tests per year should an embryologist perform per year to be experienced?
Okay, that's a very good question. I don't know the exact answer. I'm sorry, I'm not an embryologist.
Of course.
But obviously, this is like everything. They need to train, no? First of all, see their colleagues how they do the technique, then little by little do them by themselves. It's not. I don't believe it's going to be a super large number of biopsies that they need to go through to say that they are experienced. It's not such a difficult technique, and also you need to take into account that normally in the labs there will be several embryologists, so let's say like the person that is quite new to the technique is going to be always supervised by another embryologist. So well, I mean, I don't think they need so much training. It's more the supervision of their seniors that's very, very important, no?
Okay. All right. Thank you. Thank you so much. And more questions are coming in. And okay, are you able to tell, so how many years PGT has been performed, for how many years? How old are the children? So is there like a follow-up if the children after PGT have any issues, health issues, I believe here? Are there any
Okay,
studies like that?
so these are several questions. How many years PGT is done? I've been for 12 years now in the world of IVF. Since I began, it was something that was already done, not so much. The majority of the labs worked still with cleavage stage embryo development, so they did the biopsies in day 3, day 2, day 3, depending. So it was not very popular at that time, because it's true that at that stage of the embryos you only have a few cells. I'm talking about 4 to 8 cells, and you needed to take 1 or 2 cells from the embryo. For those PGT, I'm not sure about if there's any kind of illnesses. I don't think so, but I do believe it was much more harmful for the embryo, no, to be to do the implantation afterwards, or to be able to produce that ongoing pregnancy.
Mhm.
Nowadays it's very, very different. We are only taking just a few cells, as I've said, from the external part of the embryo, which will be the placenta. So there could be a small risk of harming a little bit the embryo, meaning maybe lowering a little bit the chances of that embryo to survive to the thawing or to
Mhm.
be able to implantate. But I don't believe at all that there's any damage in the proper inner cell mass or the future fetus or child. So as I know, there are no description of any illnesses because of the technique
Mhm. Okay.
itself.
Thank you. That's definitely reassuring because, of course, I'm sure there are some concerns regards to this. And there's also follow up here. So, what percentage of Down syndrome can appear after PGT? Right? Do you have? Are you able to
So in
elaborate on
particular,
this
Down
as well?
syndrome, very, very low. I mean, around 1% or so. We said that the chances of having problems after PGT-A testing is only about 5 to 10%. And in particular, in that percentage, having a Down syndrome, it's going to be lower than that. The problem
Mm-hmm.
about the Down syndrome is that this embryo normally is going, if there's an implantation, it's going to be an ongoing pregnancy. So that's why even if you've done before PGTA testing, you can still and we'll need normally to do all the screening tests during the
Mm-hmm.
first trimester in terms of looking for any chromosomic signals such as well, you need to do all the ultrasounds of the first trimester to check this, all the screening tests, and if there's any risk in having chromosomic disorders, still see if it's needed to do any other tests, as for example the NIP test, which are the blood tests
Mm-hmm.
that can be done from the 10th week of pregnancy onwards to check if there's again any chromosomical disorder, but this time with 99% reliability or accuracy. And if not, if there's still signs in the ultrasound that tell the gynecologist that there could be a problem, then we need to recheck normally with the amniocentesis that needs to be done from the 16th week of pregnancy onwards.
Yeah. All right. Thank you. Thank you so much. I think very important to of course, talk about it as well. Thank you so much. And let me have a look. Okay. Sorry, lots of questions here. A few follow-ups. So let me just try to go to the question I was looking at. Sorry, I have a delay, but I think we are all set and you can hear us properly. Please let us know, but I think it's all okay. Okay, so sorry. Do you still recommend, I will show it to you, testing if criteria is like 38 recurrent plantation failure, but there are only 1 2 embryos?
Yes, why not? If you are older than 38 years old, I do believe it's better if you do it, and more if you've done or you had several implantation failures. I believe that we do need to check before if the embryo is euploid or not, because if we keep on doing transfers of embryos that maybe are very good looking in terms of quality, but we don't know if in reality they are normal or not, we are not going to understand better if the problem is within the embryo or if there are any other factors that are complicating the implantation.
Yeah. Okay. Thank you. Thank you so much. And another point here, which I know also is a big discussion. Many times we receive this kind of question. When we already have frozen embryos, will the PGTA is it, you know, okay to do PGTA, or is it advisable, or they can be damaged and it's not possible, or how does it work?
Okay. It's true that in this particular case, It depends a little bit more in each patient. Okay, it's true that as I said, thawing the embryo, doing a biopsy, and freezing again could harm a little bit more the embryo in terms of only decreasing the chances of implantation or ongoing pregnancy. Okay, it's not going to harm in terms of having a child with an illness. All right, so it depends on the case. If it's a patient that hasn't had many transfers before, we do prefer to keep on going with the embryos that are already frozen without PGT-A testing. But if it's another particular case where we do have lots of implantation failure, maybe miscarriages as well, we've looked at other factors, we don't find a particular cause, maybe it could be a good idea. Also, perhaps for patients, for example, I just had today some patients that come from France. They have embryos over there still. They already have one child and they do want another child, but they prefer to analyze the embryos that they had left over. There were not so many, there were 3, but they wanted like to go ahead with a transfer with the maximum chances as possible. And they were talking about doing the transport of the embryos because they couldn't do the PGTA testing at their country. So they wanted to come to Spain to do so without trying another IVF for the moment, just testing those embryos, see if they had any euploid embryo for a transfer. And if not, then talk about what will be the treatment right now.
All right. Brilliant. Thank you so much again for your question and explaining this so well. And next question, I will show it to you. Do you think that PGT should be done in every embryo, on every embryo, or only when there is an indication of genetic anomaly?
So I mean, once you decide to do the PGTA testing, I don't know if I'm answering properly your question, but once you decide to go ahead, you need to normally do it to every embryo that you achieve. I don't think it's a good decision to, for example, transfer one in fresh and do the PGTA testing to the rest of them. I do prefer to test all the embryos all together, unless there's like a specific situation where we can see and talk about together. In terms of only embryos, because there's a genetical abnormality, the indication is not only that. We've said that also patients that are aged more than 35 or 38 years old is already an indication. And also if there's been several miscarriages before, implantation failures, even if they don't have chromosomic abnormalities in the karyotypes in the parents, we do advise or suggest to do a PGTA testing to all the embryos.
Okay. Right. Thank you so much for the clarification. And so how many cells from the trophectoderm would you biopsy per embryo?
So normally between 5 to 10.
Okay. You mentioned this, I know, but let's make it clear for everyone. So thanks a lot.
Okay.
And do you consider conventional IVF for PGT cases?
So, well, it's something that nowadays can be done. It depends on the case. We normally go ahead for ICSI or microinjection directly because it does improve normally. It depends on the case. The chances of fertilization. If there's like a particular case where we've seen with previous cycles that maybe classic IVF is going to be better because of the quality of the egg or something like that, we could see it's nowadays an option. It's not a problem. But I mean, it's the same as normal IVF without PGTA testing. Do you go ahead with classic IVF or with microinjection? Nowadays, I can say that more than 95% of patients, we go ahead with the microinjection.
Yeah.
So the same
Right.
for the PGTA testing.
Okay. Crystal clear. Again, thank you so much. Embryos from egg donors have 40% to be aneuploid.
Yeah, more or less. Obviously, this is not white or black,
Unfortunately.
but it's true that that's more or less the percentage of euploid embryos that they can have. And we've done PGT-A testing with egg donation, with even double donation, which is not at all always suggested, but we've seen that you do achieve aneuploid embryos as well. So that's
Mhm.
why the pregnancy rates with this type of treatments are not going to be 100%. It's around that 60 to 65% rate.
Yeah, brilliant. Thank you so much indeed. I have a few questions from Christina here, very good ones. So thanks a lot for that. So what questions should I ask the clinic to to evaluate the quality of PGTA?
So to evaluate the quality, sorry,
Of
I'm not
PGT
sure to
test, yeah?
understand.
So what kind of questions should I ask the clinic, yeah, to evaluate the quality of PGTA, the test being performed? Because that's the thing. Do you all like some? I know sometimes some clinics perform PGTA outside of the clinic, right? So how does it
Mhm.
work?
Well, if they are used to do it with other patients, if they're like they normally suggest to do it, then go ahead because probably they are well trained. There's also the possibility some clinics, and they do tell you. I think that the majority should be honest about this. If they don't have the proper training, that let's say,
Mhm.
or they don't normally suggest, but in this particular case they do believe it's better to do it. They can also have an external embryologist that comes only for the biopsy of the embryos. This is something very common in maybe
Mhm.
very small clinics where they don't perform it every day, let's say, and maybe they are beginning to be trained by, but they still call an external embryologist to do the technique. So
Mhm.
they should let you know about this. It's not something bad, let's say, and yeah, I think it's better to be honest with it.
Of course, definitely. Thank you so much. And are you able to tell us how many PGTA tests do you perform per year at your clinic?
Well, I don't know an exact number, but I believe it's quite large. So probably it could be around 30 to 40% of the total cycles. I'm not sure how many exactly, but maybe 300, 400 per year. Yeah.
Okay. All right. Again, thank you so much. Very important questions, I guess, as well, of course. So thanks a lot. So if the PGT is done on the sixth day, does it have like less chances to give pregnancy from the one tested on day 5?
Not at all. So the blastocyst stage is very important to understand that no matter the embryo is in day 5, day 6, the chances are going to be more or less the same. Sometimes the embryo is a little bit slower and takes a little bit more time to achieve like the proper blastocyst, let's say, arrangement. Um, for the biopsy, it's a little bit the same. We need to wait and see when the embryo is well expanded, has a good quality to be biopsied. If in day 5 we are not sure, or still the embryo is a little bit initial in its stage, it's preferable that we wait a little bit longer to do the biopsy and in day 6. And this doesn't mean that the chances are going to be lower at all.
All right, perfect. Thank you so much. And we are going to probably answer the last and final question for today. But of course, remember, if you have any more, you still have time. Go ahead, type those in. And the question is right here. Just give me a second. For some reason, I cannot see it now. Just give me a minute. I'm sure I can find it. So what is the percentage of implantation failure or missed abortion rate even after PGT selection of embryos? Are you able to tell us?
So implantation failure, it's around 30 to 40%, depending on each case. and miscarriage should be quite low, like around 10% still, not normally because chromosomic disorders, but sometimes the embryo is not able to do the implantation itself, or it does implantate, but it's not able to get divided afterwards and let's say do an ongoing pregnancy. So it not very large percentages, but still there's a slight possibility.
Right. Okay. We need to remember that as well, of course. Thank you so much. And sorry, I think I missed this. So once again, so Christina asked what percentage of embryos after PGT do not survive from defreezing? This is the
So
last
this
question. Yeah.
percentage, yeah, this percentage is very, very low. It's around only 1%. I mean, the blastocysts are very powerful, as I say. They have a very large potential, and the probability of survival after the thawing is around 99%. No matter if you've done the PGT testing or not, the percentages are going to be very similar. It's true that the embryologists only biopsy and freeze normally the embryos that are really, really good looking, very nice morphology, and therefore the rates are going to be very good for the thawing.
Okay. Thank you so much. Lots of questions today, but I think it's very on-point questions, and I think that we've been able to look at different aspects of PGTA, yeah, as the title says, risk and benefits, and we definitely were able to explore that. So thanks a lot, everyone. I think we will be finishing for today, but remember that if you have more questions, you can always send those to us, and also you can get in touch with Dr. Santiago and her team at VIDA Fertility, and I'm sure they will be more than happy to help you out with any questions that you might have. Thank you so much, Dr. Santiago. Thank you, everyone, for joining. It's been a great session indeed. Any final comments before we finish for today?
Well, thank you again to invite me for another webinar. It's always a pleasure. I'm happy to learn with you, to explain different things each time, and obviously looking forward for the next one.
Definitely. Thank you so much indeed. In the meantime, we did receive the is your clinic performing IVF for someone who is 54? If you can explain, because I know in Spain it's a bit tricky here when it comes to that.
Yeah,
Right?
so it's true that there's no a low limit, let's say, but the majority of clinics are going to be or put their limit at a particular time, which is normally 50 years old. And we also think that for us, like the maximum is 50 years old. I'm
Gosh,
sorry.
thank you so much for the
Yeah.
clarification. This is important, of course, to know and to be aware of. So thank you a lot. And as always, if there's anything else, remember we are here to discuss many various topics, and I'm sure Dr. Santiago will be back. And in the meantime, let me invite everyone we will discuss tomorrow recurrent implantation failure. So if this is something you are also wondering, you have some questions, you can join us tomorrow. We will be live at 7 p.m. London time. You can find all of our upcoming events on our website, myivfenses.com. And I'm really looking forward to some more events. Of course, Dr. Santiago, thank you so much for joining. Thank you, everyone, for being with us today. And have a lovely evening, okay? Have a relaxing evening, and take care. See you soon. Bye.
Thanks again. Thank you. Bye. Take care.